Right. Hi, good evening, everyone. I am Andrea Rajnath, and I'll be going through vertebral anatomy and trauma management of the thoraco-lumbar and sacral region. So first, we will go through the vertebral anatomy of the thoraco-lumbar and sacral region. So the thoracic spine is the second segment of the vertebral column, consists of 12 vertebrae, which are separated by intervertebral disc, and this, along with the sternum and the ribs, form the thoracic cage, right? So there's some general features of the vertebral column. They consist of a vertebral body, spinous processes, transverse process, pedicles, lamina, and articular processes. For the thoracic vertebrae, they have some specific features, such as a heart-shaped vertebral body, has demifacets on each side of each vertebral body, which articulates with the heads of the ribs, has costal facets on the transverse processes, which articulate with the tubercles of the ribs, has long spinous processes, which are oriented obliquely, inferiorly, and posteriorly, and has a circular-shaped vertebral foramen. Of note, it should be mentioned that T4 vertebrae, on average, has the thinnest diameter and shortest length pedicle. And this is important for when having to place screws in surgery at the lower thoracic spine. It's always advised to place screws more at the lower thoracic spine. Um, so it should also be noted that for the nerve roots of the spinal cord, for the cervical region, the cervical nerve roots are numbered according to the cervical vertebrae above which they pass. So meaning that the C1 nerve root pass above the C1 vertebrae. However, there are 7 cervical vertebrae, but 8 pairs of cervical nerves. So therefore, the C8 nerve root exits above T1. From this level at T1, the corresponding nerve root passes below the corresponding vertebrae. So that means the T1 nerve root exits below the T1 vertebrae. Right? We also have some atypical thoracic vertebrae, such as the T1, which has a superior facet, is not a demifacet as it articulates with the first rib. T10 has a single pair of whole facets, which articulate with the 10th rib. And T11 and T12 each have a single pair of whole costal facets located on the pedicles. We then move on to the lumbar spine, which is the third segment of the vertebral column and consists of 5 lumbar vertebrae. It has the largest vertebrae of the entire spinal column, and this is because it's specialized for weight bearing. All right, so it lacks characteristic features of other vertebrae with no transverse foramina, costal facets, or bifid spinous processes. Specific features for the lumbar vertebrae is it has a large kidney-shaped vertebral body. It's greater in height anteriorly than posteriorly, creating a lumbosacral angle. Its triangular-shaped vertebral foramen. Transverse processes are long and slender. The articular processes have nearly vertical facets. The spinous processes are short and broad. Accessory processes can be found on the posterior aspect of the base of each transverse process, and mammillary processes can be found on the posterior surface of each superior articular process. Right, so this is just a table comparing the joints and ligaments present throughout the vertebral column. Those are specific to the thoracic spine, and those are specific to the lumbar spine. Right, so in regards to the joints, throughout the vertebral column, they have facet joints and vertebral body joints. Only present specifically at the thoracic spine is the costovertebral joints and the costotransverse joints, with the exception of T11 and T12. In regards to ligaments for the thoracic spine, only thoracic spine has the radial ligament of the head of the rib, costotransverse ligaments, lateral costotransverse ligaments, and the superior costotransverse ligaments. In regards to the lumbar spine, this is the only area that has the iliolumbar ligaments. For the sacrum, so the sacrum is formed by the fusion of 5 sacral vertebrae. It is described as an inverted triangle with a concave shape. So it has four surfaces, a base which articulates superiorly with the lumbar vertebra and is associated intervertebral disc, an apex which abuts the coccyx inferiorly, an auricular surface, located laterally on the sacrum and articulates with the auricular surface of the ilium, and anterior and posterior surfaces which provide attachment to pelvic ligaments and muscles. The central canal of the vertebral column continues along the core of the sacrum and ends at the fourth sacral foramina, known as the sacral hiatus. Right, so the posterior surface of the sacrum, this surface is coarse due to the fusion of the vertebrae and consists of three bony ridges or crests. So the median sacral crest is formed by the fusion of the spinous processes of the first three sacral vertebrae and gives attachment to the supraspinous ligament. The intermediate sacral crest formed by the fusion of the sacral articular process. The superior articular process of S1 is not fused and articulates with the inferior articulating process of L5, and the inferior articular process of S5, also known as the sacral cornu, is not fused and articulates with the coccygeal fornu. The lateral sacral crests are formed by the fusion of the transverse processes of 5 sacral vertebrae. The fusion of these processes is not complete, allowing the sacral nerve fibers to enter and leave the central canal by the way of 4 pairs of posterior sacral foramina. So the anterior surface of the sacrum, this surface is smooth and is marked by 4 transverse lines, which are the remnants of the fused sacral intervertebral disc. Superiorly, there's an anterior projection of bone known as the sacral promontory. The central canal of the sacrum contains sacral fibers of the chorda equina. The proximal part of these fibers are contained within a dural sac, which terminates at the level of S2. Just a quick mention of the coccyx. This is the terminal part of the vertebral column. It's a small bone which articulates with the apex of the sacrum. It's comprised of 4 vertebrae fused to form a triangular shape and is recognized by the lack of vertebral arches, and due to this, there's no vertebral canal. Right, so we will now move on to the trauma of the thoraco-lumbar and sacral region. So first thing we need to talk about is the Dennis stream column model of the spine, which uses CT criteria to identify instability of the thoraco-lumbar spine fractures. So it divides the spine into 3 columns. So the anterior column consists of the anterior half of the disc and vertebral body, and this also includes the anterior half of the annulus fibrosus, plus the anterior longitudinal ligament. The middle column consists of the posterior half of the disc and vertebral body, and also includes the posterior wall of the vertebral body, as well as the posterior half of the annulus fibrosus and the posterior longitudinal ligament. The posterior column consists of the posterior arch with the interposed posterior ligamentous complex. And, well, injury to this column alone typically does not cause instability with flexion. Right, so how we will classify thoraco-lumbar fractures. So we typically classify it as minor or major injuries. So a minor injury is one that only involves one column and does not lead to acute instability. Some examples of these are fractures of the transverse process, fracture of the articular process or pars interarticularis, isolated fractures of the spinous processes, or isolated laminar fracture. Major injuries are divided into 4: compression, burst, seatbelt, or fracture dislocation. So a compression fracture, this is compression failure of the anterior column and the middle column being intact. The posterior column may or may not be intact. It may be distracted if the fracture is severe, right? It's caused by axial compression alone or flexion forces when the spine is bent forward or in side flexion. The most common cause in younger patients tend to be falls from a height or motor vehicle accident. In older patients, these could be due to minor incidents of normal activity due to osteoporosis or bone disease, right? It's considered a stable fracture, and usually there's no neurological deficit. There are two subtypes: anterior, most commonly occurs between T6 to T8 and T12 to L3, and lateral, which are rare. We then have a burst fracture. This involves compression of the vertebral body, anterior and middle columns. The posterior column may or may not be involved. It often occurs between T10 and L2, commonly caused by axial loading of the anterior spine, right? Such as a fall, landing on the buttocks or lower extremities, where concentration of the axial forces is at the thoraco-lumbar junction. Sometimes it's accompanied with retropulse bone fragments into the spinal canal, so therefore neurological injury is more common in this type of fracture. 50% of patients are neurologically intact at initial examination. Of these patients with deficits, 5% had complete paraplegia. There are also 5 subtypes of the burst fracture: fracture of both end plates, fracture of superior end plate, fracture of the inferior end plate, both burst rotation and burst lateral flexion. Right? So this is a picture showing a burst fracture on the lateral X-ray. You would typically see features showing a cortical feature of posterior vertebral body wall, loss of posterior vertebral body height, retropulsion of bone fragment from end plates into canal. On the AP X-ray, you may also see increase of the interpediculate distance, vertical fracture of the laminar spline of the facet joints, and increase of the interpediculate distance, which indicates a failure of the middle column. Right? This is a slide showing a burst fracture on CT as well as a burst fracture on MRI. Seatbelt fracture, this is also known as a flexion distraction fracture, is an intact or mild compression of the anterior column with distraction of the middle and posterior column. Trauma involving sudden, this usually occurs when there's trauma involving sudden upper body forward flexion while the lower body remains stationary. A gap between the spinal processes is often present upon palpation. There's usually no neurological deficits. And there are 4 subtypes: chance fracture, which is horizontal, one level through the bone only, with splitting of the spinous processes, laminae, pedicles, and vertebral body. If there's one level, through the ligaments. If 2 levels are involved, through bone in the middle column and through ligaments in the anterior and posterior columns. And if it's 2 levels involved, through ligaments in all 3 columns. All right, so identifying a seatbelt fracture on plain X-ray, there's usually increase in the interspinous distance, pars interarticularis fractures, and horizontal split of the pedicles and transverse process. There's no subluxation. CT on axial view is poor for this type. It's usually recommended to do sagittal or coronal reconstructions, which may disclose a pars fracture. MRI may be done to check for canal compromise or ligamentous injury. So a fracture, dislocation fracture, this is failure of all 3 columns due to compression, tension, rotation, or shear forces, right? Resulting in subluxation or dislocation. This is a very unstable fracture and highly associated with neurological deficits. There are 3 subtypes: flexion rotation, shear, and flexion distraction subtype of fracture dislocation. All right, so this is an X-ray. You can also do a CT scan where you're indicated for assessment and surgical planning, and you may also do an MRI to assess nerve involvement as well as ligament involvement. So presentation of thoraco-lumbar fracture. So these patients are usually involved in a high energy injury, but if it being like a fall from a high to a high speed motor vehicle accident. Typically, they complain of severe back pain, radicular pain, or paresthesia. Right? These patients may also present in hypotension, right? This may be due to neurogenic shock with associated bradycardia, which suggests a spinal cord injury. or it may be due to hypovolemic shock with a compensatory tachycardia. Right? Skin abrasion and ecchymosis to the thoracolumbar region is suggestive of possible fracture. It's recommended that you palpate the spinous processes, looking for fluid collection, crepitus, increased interspinous distance, or localized tenderness. You will also do assessment of the motor sensation and reflexes. Neurological deficits in these injuries can range from normal neurologic function to complete spinal cord injury. One thing we should also talk about is the cauda syndrome versus conus medullaris syndrome. Sorry about that mistake. Right, so cauda syndrome results from simultaneous compression of multiple lumbosacral nerve roots below the level of the conus medullaris. Right, whereas conus medullaris syndrome is caused by a compressive injury or insult to the conus medullaris and lumbar nerve roots. Typically, the injury is at the level of T12 to T2. This is a table just showing the differences between cauda syndrome and conus medullaris syndrome. So the pain in cauda syndrome is usually severe and asymmetric, whereas in conus medullaris it's uncommon. Sensory loss is usually asymmetric in cauda equina, whereas in conus medullaris is symmetric and they have saddle anesthesia. Motor deficit in cauda equina is asymmetric with more prominent wasting. In conus medullaris is symmetric and less prominent. Reflexes for cauda equina are diminished and maybe asymmetric. Conus medullaris, only the ankle jerk is lost. Plantar reflexes, you get a flexor plantar reflex for the cauda equina, whereas for conus medullaris, you may get an extensor response. For cauda equina syndrome, it's less common to have sphincter involvement and is usually a late feature. For conus medullaris, it's very common and an early feature. So the management of thoraco-lumbar fractures. So minor injuries are typically considered stable and managed conservatively, whereas major injuries can be further categorized based on instability. First degree being mechanical instability, second degree neurological instability, third degree being mechanical and neurological instability. One thing we should also mention is the thoraco-lumbar injury classification and severity score, which has been proposed to simplify the classification and discussion of thoraco-lumbar fractures. So it's a point system and it's based on different parameters, based on injury morphology, the posterior ligamental complex integrity, and the neurological status. And based on the point system, it guides you whether if you could do conservative, whether you could decide whether if you want to go conservative with the surgery route or where surgery route is definitive. So management of thoraco-lumbar fractures. In an isolated anterior column fracture, it's considered stable and managed conservatively. This usually involves analgesia, bed rest, external bracing, and serial x-rays. Unstable anterior column fractures require surgery. These include a single compression fracture with more than 50% loss of the height and with angulation. If there's excessive kyphotic angulation at one segment. If there's 3 or more contiguous compression fractures, neurological deficit, disrupted posterior column, or more than minimal middle column failure. If there's progressive kyphosis, right, the risk of progressive kyphosis is increased when there's a loss of height of the anterior body greater than 75%. Middle column fractures are unstable and often require surgery. There are some exceptions which are considered stable and managed conservatively, which are above T8 if the ribs and sternums are intact, below L4 if posterior elements are intact, a chance fracture, or anterior column disruption with minimal middle column failure. Posterior column injuries are typically not acutely unstable unless accompanied with a middle column injury. Seatbelt type injuries without neurological deficit can be treated with just external mobilization device and extension. Fracture dislocation injuries are considered to be unstable and require surgical decompression and stabilization, right? This is indicated when there's compression with more than 50% loss of height with angulation, kyphotic angulation greater than 40 degrees, neurological deficit, or if you desire to shorten the time of bed rest. They can also be managed with prolonged bed rest. Burst fractures require surgical intervention in the following cases: anterior vertebral body height less than 50% of the posterior height if there's residual canal diameter less than 50% of normal, kyphotic angulation greater than 20 degrees, when the interpedicellate widens further on AP X-ray when standing in brace or cast, if there's a neurological deficit or progressive kyphosis. Common surgical options for burst or severe compression fractures include pedicle screws can be placed 2 levels above and 2 levels below the fracture. If the fracture level can be included, meaning if the pedicles are intact enough, you can do placing screws at the fracture level and just 1 level above and 1 level below. If decompression of the spinal canal and or anterior support is needed, it's recommended you do a corpectomy and strut graft where pedicle screws may be used. You can go the posterior approach, which is a laminectomy, with transpedicular approach and impacting both anteriorly out of the canal with a mallet and a reverse angle Scoville curette, or lateral corpectomy and removal of bone with the canal, from the canal, sorry. For burst fractures, those not undergoing surgery may be managed with strict bed rest for 1 to 6 weeks, then can begin ambulation in an orthosis and follow up. You can continue to follow up the patient for 3 to 5 months, with serial X-rays to detect progressive collapse or angulation, which may need further intervention. Sacral fractures, these are uncommon and usually caused by shear forces, being involved in a motor vehicle accident or fall from a height, or can also be due to repetitive stress. Soft tissue trauma around the pelvis should raise concern for a pelvic or sacral fracture. Neurologic injuries occur in 22 to 60% of these patients. It has a bimodal distribution in young adults, usually due to high energy trauma, and in the elderly due to low energy falls. 17% of patients with pelvic fractures have associated sacral fracture. Right? So the imaging you can do to detect a sacral fracture. So for X-ray, only 30% of sacral fractures are identified, and the recommended views are the pelvic views, which are AP, lateral inlet and outlet. CT is the diagnostic study of choice, and MRI is recommended if there's neural compromise suspected. So the classification of sacral fractures: Zone 1 being the region of the alar, sparing the central canal and the neural foramina. This is most common type of sacral fracture, being 50%, and occasionally is associated with a partial L5 root injury in about 5% of patients. Zone 2, region of the sacral foramina sparing the central canal, right? This could be unstable or stable, and it may be associated with L5, S1, and or S2 nerve root involvement. Bladder dysfunction is rare. Zone 3 is involves the region of the sacral canal and may be associated with sphincter dysfunction and tunnel anesthesia, which occurs in about 60% of patients. There are 3 subtypes: vertical, transverse, which is rare, and U-shape. U-shape, zone 3 sacral fractures are also known as suicide jumpers fracture. It involves a bilateral longitudinal fracture connected by a transverse fracture at S2, S3. These are considered to be unstable and may also be seen with sacral insufficiency fractures, which tend to be H-shaped instead of U-shaped. Right, so this is a diagram showing the 3 zones of fractures. So the zone 1 involving the alar, zone 2 and zone 3, where it involves the canal. And then this is a diagram showing the different types of the zone 3 sacral fractures. And here you can see the U shape and the H-shape sacral fracture. So the management of sacral fractures, you can do non-operative with progressive weight bearing, plus or minus orthosis. This is indicated if there's less than 1 centimeter displacement and no neurological deficit, right? Then there's the operative route where you could do surgical fixation. Some of the options include percutaneous screw fixation, posterior tension, band plating, iliosacral and lumbopelvic fixation. This is indicated in displaced fractures greater than 1 centimeter if there's soft tissue compromise, persistent pain after non-operative management, displacement of the fracture after non-operative management. You can also do surgical fixation with decompression, which can be achieved through axial traction, laminectomy, or forainotomy. This is indicated when there's evidence of a neurological injury. Thank you.